At the Family Medical Center, two people came in with progressive fatigue. One of them is a 60-year-old named Will, whose past medical history included an aortic valve replacement with a mechanical valve due to severe aortic stenosis. And then there's Hannah, a 28-year-old female of African descent. She was diagnosed a year ago with systemic lupus erythematosus, or SLE. CBC is ordered for both people and it shows low hemoglobin with normal mean corpuscular volume, or MCV, and reticulocyte count index over 2%. They also have increased LDH. Now, Will has schistocytes on peripheral blood smear, while Hannah has spherocytes. Both Will and Hannah are suffering from anemia, which is defined as lower than average levels of hemoglobin, typically below 13.5 grams per deciliter in adult men, and below 12 grams per deciliter in adult women. For children, this level varies based on the age. Now, anemias can be broadly grouped into three categories based on MCV, which reflects the volume of a red blood cell. So microcytic anemia is where the MCV is lower than 80 femtoliters, normocytic with an MCV between 80 and 100 femtoliters, and macrocytic with an MCV larger than 100 femtoliters. Normocytic anemias can be further classified as hemolytic when there's increased destruction of red blood cells, or hemolysis, and non-hemolytic when there's decreased production of red blood cells from the bone marrow. When there's hemolysis, the bone marrow revs up and starts pumping out immature red blood cells called reticulocytes. But when there's a bone marrow problem, reticulocyte count is low. So for your exams, it's important to know that in hemolytic anemias, there's an increased reticulocyte production index of over 2%, while in non-hemolytic anemias, it's lower than 2%. Alright, now hemolytic anemias can be classified as intrinsic or extrinsic hemolytic anemias. In intrinsic hemolytic anemias, red blood cells are destroyed because they're defective, while in extrinsic hemolytic anemias, red blood cells are normal, but are later destroyed outside the bone marrow. In this video, let's focus on extrinsic hemolytic anemias that include autoimmune hemolytic anemia, microangiopathic hemolytic anemia, macroangiopathic hemolytic anemia, and infections. Now we can divide extrinsic hemolysis into intravascular, meaning red blood cells are destroyed within the vasculature, or extravascular, meaning that they're removed by macrophages in the spleen and liver. Microangiopathic and macroangiopathic hemolytic anemias are intravascular. Autoimmune hemolytic anemia is usually extravascular, while infections can cause both intravascular and extravascular. There are findings that can help identify the type of hemolysis. In intravascular hemolysis, hemoglobin that's released inside the vessels gets bound by a protein called haptoglobin, and because they're removed together, haptoglobin decreases. Also, when haptoglobin gets overwhelmed, the rest of hemoglobin goes via the blood through the kidneys and into the urine, resulting in hemoglobinuria. Now, when hemoglobin is inside the renal tubules, the cells lining the renal tubules reabsorb hemoglobin. The heme component of hemoglobin contains iron, which is stored as hemosiderin in tubular cells, and after a few days, when tubular cells slough into urine, there's hemosideриnuria. Hemoglobinuria and hemosideриnuria can damage the kidneys, causing back pain. Alright, now in extravascular hemolysis, red blood cells are destroyed outside the vessels, and so haptoglobin is normal, and there's no hemoglobin or hemosiderin in the urine. Red blood cells are usually destroyed in the spleen, causing splenomegaly, or the liver, causing hepatomegaly. Alright, now whenever there's red blood cell lysis, an intracellular enzyme called lactate dehydrogenase, or LDH, spills out directly into the plasma and builds up in the blood. Hemoglobin also spills out of the cells and breaks up into globin and heme. Heme is converted into unconjugated, or indirect, bilirubin, which is then taken up by the liver cells and eventually secreted out with bile. If all of a sudden your body starts breaking down more red blood cells than the liver cells can handle, the excess bilirubin stays in the blood and can cause jaundice, where the bilirubin deposits in the skin and the eyes, causing them to turn yellow. Also, when there's too much bilirubin in the bile, it can form pigmented gallstones. Some of the bilirubin is converted to urobilin, which is what gives urine that yellow color. But if there's too much of it, the urine becomes a much darker tea-like color. Alright, so let's take a closer look at these different extrinsic hemolytic anemias, starting with autoimmune hemolytic anemia, where antibodies in complement are directed against red blood cells, leading to their destruction. It's like the red blood cell equivalent of immune thrombocytopenic purpura, or ITP, a disorder where autoantibodies bind to the platelet receptor and cause them to be targeted by immune cells in the spleen for destruction. In fact, some patients develop both conditions together, and that's called Evans syndrome. Based on the type of antibodies produced, autoimmune hemolytic anemia can be divided further into IgG, also called warm antibody hemolytic anemia, and IgM hemolytic anemia, also called cold agglutinin disease. Now, it's important to remember the causes, since they might be the best clues for identifying autoimmune hemolytic anemia in the exams. Warm antibody hemolytic anemia is typically seen in chronic lymphocytic leukemia, or CLL, as well as systemic lupus erythematosus, or SLE, and with the use of antibiotics like penicillins and cephalosporins, sulfa drugs, and the antihypertensive drug methyldopa. Cold agglutinin disease is often seen in CLL, Waldenstrom macroglobulinemia, and a rare type of malignant lymphoma, and infections like infectious mononucleosis and Mycoplasma pneumoniae infections. Next up is microangiopathic hemolytic anemia that occurs in the small blood vessels, and include thrombotic thrombocytopenic purpura, or TTP, hemolytic uremic syndrome, or HUS, and disseminated intravascular coagulation, or DIC. In these disorders, there's excessive clot formation, so when normal red blood cells flow through these blood vessels, they get banged up and damaged, leading to intravascular hemolysis. In TTP, there's a deficiency of ADAMTS13, a metalloproteinase that breaks von Willebrand factor, a protein needed for the formation of clots and their adhesion to the endothelial lining. So when there's not enough ADAMTS13, there's excessive clot formation, and these clots end up damaging red blood cells. TTP can be caused by a genetic mutation, or it can develop after exposure to antiplatelet medications like ticlopidine and clopidogrel, or chemotherapeutic agents like cyclosporine and gemcitabine. In some cases, it can also be associated with diseases like systemic lupus erythematosus. Alright, moving on to HUS. Typical HUS happens after an infection by a Shiga toxin bacteria. The most common is Escherichia coli, but others include Shigella and Salmonella. A high-yield fact for your exams is that this often occurs in children after an episode of gastroenteritis, caused by these bacteria. The toxins they release destroys colonic epithelial cells, causing bloody diarrhea, and then enters the circulation, where it damages the endothelial cells, causing massive release of von Willebrand factor and excessive clot formation throughout the body. Typical HUS has good prognosis. Now, the atypical HUS is not associated with Shiga toxin. It can happen at any age and has a relatively poor prognosis. It's linked to a genetic mutation in factor H, a protein that controls the complement system. Without it, the complement system goes wild, causing damage to the endothelial cells and excessive clot formation. Next up is DIC, where there's a massive overactivation of the coagulation system in response to something like sepsis or trauma. This leads to widespread clotting, organ ischemia, and microangiopathic hemolytic anemia, while at the same time depletes platelets and clotting factors, which paradoxically leads to bleeding. Alright, now microangiopathic anemia can also happen in hypertensive emergencies, and in HELP syndrome, which is an acronym for a triad of findings: H for hemolysis, EL for elevated liver enzymes, and LP for low platelets. HELP happens as a complication of preeclampsia and eclampsia, which are hypertensive disorders in pregnancy. High blood pressure can damage the vascular endothelium and activate the coagulation cascade, leading to the formation of blood clots, depleting the platelets. The clots are responsible for the destruction of red blood cells as they circulate through the clotted vessels. The clots also deposit in the hepatic blood vessels, causing congestion and increased intrahepatic pressure, leading to liver damage. Alright, moving on to macroangiopathic hemolytic anemia, where the destruction of red blood cells happens in the larger vessels. Actually, most of the time, this happens inside the heart. One example is aortic stenosis, where the red blood cells are damaged when squeezing past the damaged valves. Prosthetic heart valves can also cause the same problem. Hemolysis also happens with a parasitic infection, like Plasmodium falciparum, that causes malaria, and Babesia species, a tick-transmitted parasite that causes babesiosis. These parasites love to infect and live inside red blood cells, eventually causing them to rupture, leading to hemolysis. Alright, now all types of hemolytic anemia can present with symptoms of anemia, like fatigue, pallor, and shortness of breath. Hemolysis presents as jaundice, dark or tea-colored urine, and back pain due to kidney damage. Also, when there's extravascular hemolysis, there's splenomegaly or hepatomegaly. But in the exams, more specific symptoms will often help you identify the particular disease. For example, autoimmune hemolytic anemia can happen suddenly with fever, syncope, and congestive heart failure. In addition, in cold agglutinin disease, when individuals are exposed to cold temperatures, IgM antibodies react with red blood cell antigens and make them agglutinate, or clot. A high-yield fact to remember is that these clots cause cyanosis and pain in the coolest areas of our bodies, like ears, nose, fingers, and toes. Moving on to microangiopathic hemolytic anemia. For TTP, individuals classically develop 5 symptoms: thrombocytopenia causing mucocutaneous bleeding, microangiopathic hemolytic anemia, fever, renal insufficiency, which can cause hematuria and decreased urine output, and neurologic symptoms like headache and confusion. Now, HUS is clinically similar to TTP. The classic presentation is a triad of thrombocytopenia, renal insufficiency, and microangiopathic hemolytic anemia. These appear 5 to 10 days after the gastroenteritis episode in typical HUS, or can happen on their own in atypical HUS. A very high-yield concept to remember is that unlike TTP, HUS does not usually cause a fever or neurological symptoms, and instead the renal insufficiency symptoms predominate. In DIC, initially the patient is more likely to clot, and that leads to overconsumption of the coagulation factors, including fibrinogen and platelets. Then there's a period in which the patient is more likely to bleed, like from venipuncture sites. Macroangiopathic hemolytic anemia presents with the nonspecific symptoms of anemia and symptoms of hemolysis. Now, if there's hemolysis during an infection, like in malaria, symptoms might include fevers, headaches, extreme fatigue, and symptoms of hemolysis, like jaundice and splenomegaly. Moving on to diagnosis. The most specific test to diagnose autoimmune hemolytic anemia is the positive Coombs test. Direct Coombs test detects antibodies or complement found in the red blood cell membrane, while indirect Coombs indicates the presence of antibodies in the serum. On the peripheral blood smear, spherocytes are often present. Spherocytes are small, round, dysmorphic red blood cells with more intensely stained cytoplasm and no central pallor. But they're nonspecific for autoimmune hemolytic anemia, and are also present in hereditary spherocytosis. Coombs test, which is negative in hereditary spherocytosis, can help distinguish these two conditions. Alright, in microangiopathic and macroangiopathic hemolytic anemia, an important clue is the presence of schistocytes on peripheral blood smear. These are red blood cells that break apart the bloodstream, forming cell fragments or helmet cells, which look like little red helmets with pointed ends after a bit of the cell broke off. Now, lab findings can help you identify the specific type of microangiopathic hemolytic anemia. In TTP, a CBC will show thrombocytopenia. Creatinine levels might be elevated if there's kidney damage. Markers of secondary hemostasis like prothrombin time, or PT, and partial thromboplastin time, or PTT, are normal, because they're not involved in formation of the von Willebrand factor multimers and platelets. Laboratory studies in HUS are similar to TTP. In a child where typical HUS is suspected, stool cultures can be sent off to look for E. coli. In DIC, there's usually thrombocytopenia and a prolonged PT and PTT. Additionally, fibrinogen levels are decreased and there are elevated D-dimer levels, which indicate accelerated clot lysis. Now, to diagnose an infection as the cause of hemolysis, you need to confirm the presence of the causative organism. For example, malaria is usually diagnosed with a blood smear that shows the parasites sitting within the red blood cell. Alright, as a quick recap. Extrinsic hemolytic anemias include autoimmune hemolytic anemia, microangiopathic hemolytic anemias like TTP, HUS, and DIC, macroangiopathic hemolytic anemia due to prosthetic heart valves and aortic stenosis, and infections causing hemolysis like malaria and babesiosis. A diagnosis can be made based on clinical presentation, lab findings, peripheral blood smear, and more specific tests like Coombs test. Now back to the patients. Both of them have normocytic hemolytic anemia. Due to his history of aortic valve replacement and the presence of schistocytes on peripheral blood smear, Will most likely has macroangiopathic hemolytic anemia. Now, Hannah, due to her history of SLE and the presence of spherocytes on blood smear, she could have warm antibody hemolytic anemia. A positive Coombs test will confirm the diagnosis.
On the hematology ward, there's a mother with her daughter, Kira, a 5-year-old that's developed jaundice and complains of easy fatigability. She's an adopted child with an unknown family history. Clinical examination reveals a palpable spleen. Next to her, there's a 35-year-old person of African descent named Darnell, who started trimethylprim sulfamethoxazole for treatment of acute prostatitis a few weeks ago. Recently, he developed jaundice, dark urine, back pain, and fatigue. There's also a father who brought Billy, his 13-year-old son, to the emergency department because of a painful and prolonged erection. CBC is ordered for all of them, and it shows low hemoglobin with normal MCV and reticulocyte count index over 2%. They also have increased LDH. Now, Kira also has an increased MCHC and spherocytes on peripheral blood smear, while Billy has sickled cells. Although their symptoms are very different, they all suffer from anemia, which is defined as lower than average levels of hemoglobin, typically below 13.5 grams per deciliter in adult men and below 12.0 grams per deciliter in adult women. This level varies based on age for children. Now, anemias can be broadly grouped into 3 categories based on mean corpuscular volume, or MCV, which reflects the volume of a red blood cell. So, microcytic anemia is where the MCV is lower than 80 femtoliters, normocytic with an MCV between 80 and 100 femtoliters, and macrocytic with an MCV larger than 100 femtoliters. Normocytic anemias can be further classified as hemolytic when there's increased destruction of RBCs, or hemolysis, and non-hemolytic when there's decreased production of RBCs from the bone marrow. When there's hemolysis, the bone marrow revs up and starts pumping out immature RBCs, called reticulocytes. But when there's a bone marrow problem, reticulocyte count is low. So for your exams, it's important to know that in hemolytic anemias, there's an increased reticulocyte production index of over 2%, while in non-hemolytic anemias, it's lower than 2%. Alright. Now, hemolytic anemias can be classified as intrinsic and extrinsic hemolytic anemias. In intrinsic hemolytic anemias, the RBCs are destroyed due to RBC membrane defects, like in hereditary spherocytosis and paroxysmal nocturnal hemoglobinuria, or PNH. Enzyme deficiencies, like in glucose 6-phosphate or G6PD deficiency and pyruvate kinase deficiency, and hemoglobin abnormalities, like in sickle cell anemia. Now, in extrinsic hemolytic anemias, the RBCs are normal but are later destroyed via extrinsic mechanisms, such as autoantibodies directed against RBCs. In this video, let's focus on intrinsic hemolytic anemias. Now, we can also divide intrinsic hemolysis into intravascular, meaning RBCs are destroyed within the vasculature, or extravascular, meaning they're removed by macrophages in the spleen and liver. Hereditary spherocytosis and pyruvate kinase deficiency cause extravascular hemolysis. PNH causes intravascular, while G6PD deficiency and sickle cell anemia can cause both intravascular and extravascular hemolysis. There are findings that can help identify the type of hemolysis. In intravascular hemolysis, hemoglobin that's released inside the vessels gets bound by a protein called haptoglobin, and because they're removed together, haptoglobin decreases. Also, when haptoglobin gets overwhelmed, the rest of the hemoglobin goes via the blood, through the kidneys, and into the urine, resulting in hemoglobinuria. Now, when hemoglobin is inside the renal tubules, the cells lining the renal tubules reabsorb hemoglobin. The heme component of hemoglobin contains iron, which is stored as hemosiderin in tubular cells, and after a few days, when tubular cells slough into urine, there is hemosideриnuria. Hemoglobinuria and hemosideриnuria can damage the kidneys, causing back pain. Okay, now in extravascular hemolysis, RBCs are destroyed outside the vessels, and so haptoglobin is normal, and there's no hemoglobin or hemosiderin in the urine. RBCs are usually destroyed in the spleen, causing splenomegaly, or the liver, causing hepatomegaly. Alright, now whenever there's RBC lysis, an intracellular enzyme called lactate dehydrogenase, or LDH, spills out directly into the plasma and builds up in the blood. Hemoglobin also spills out of the cell and breaks up into globin and heme. Heme is converted into unconjugated or indirect bilirubin, which is then taken up by the liver cells and eventually secreted out with bile. If, all of a sudden, your body starts breaking down more RBCs than the liver cells can handle, the excess bilirubin stays in the blood and causes jaundice, where the bilirubin deposits in the skin and the eyes, causing them to turn yellow. Also, when there's too much bilirubin in the bile, it can form pigmented gallstones. Some of the bilirubin is converted to urobilin, which is what gives urine that yellow color. But if there's too much of it, the urine becomes a much darker tea-like color. Okay, so first, let's look at intrinsic hemolytic anemias caused by RBC membrane abnormalities, which include hereditary spherocytosis and PNH. Hereditary spherocytosis is an autosomal dominant disorder characterized by defects in the spectrin and ankyrin proteins found in the RBC membrane. This results in abnormally shaped RBCs that are more spherical instead of the normal flexible biconcave discs. The spherocytes get trapped and destroyed in the spleen, resulting in chronic, mild extravascular hemolysis. Next is paroxysmal nocturnal hemoglobinuria, PNH, a genetic disorder caused by a mutated PIG-A gene in myeloid stem cells. This gene encodes for a protein called phosphatidylinositol glycan A that's needed to synthesize another protein called GPI anchor. GPI anchor is found in the membrane of all types of blood cells and serves to anchor proteins like decay accelerating factor, or DAF, also known as CD55 and CD59, to the cell membrane. These proteins normally inactivate the complement, and so they protect the cells from complement lysis. So for your exams, remember that in PNH, the complement stays activated and causes intravascular hemolysis. Another important fact to remember is that since PNH affects stem cells, it can cause aplastic anemia or pancytopenia. It also affects other blood cells, like platelets, and can cause formation of blood clots and thrombosis. So, an important clue to help you identify this disorder is that the patient can have thrombosis, hemolytic anemia, and reduced blood cell counts. In some cases, it could even lead to leukemia. Alright, moving on to intrinsic hemolytic anemia due to enzyme defects. The most common is G6PD deficiency, an X-linked recessive disorder characterized by decreased levels of an enzyme called G6PD. It almost exclusively manifests as a disease in males, while females are carriers, and is more common in individuals of African, Mediterranean, and Asian descent. G6PD deficiency leads to hemolysis by making RBCs susceptible to damage caused by free radicals. Free radicals, which are products of metabolism, can destroy RBCs, but normally, a molecule in our body called glutathione neutralizes them. Glutathione needs to be in the reduced state, where it can donate protons and electrons to the H2O2 and convert them into water. This causes glutathione to become oxidized, so before it can get back to work, an enzyme called glutathione reductase uses NADPH to reduce the oxidized glutathione, and NADPH becomes NADP+. So to replenish the supply of NADPH, we have G6PD, which reduces NADP+ back to NADPH. Okay, so in G6PD deficiency, low levels of G6PD causes low levels of NADPH, leading to low levels of reduced glutathione and increased susceptibility to hemolytic episodes caused by free radicals. Hemolysis usually happens in response to certain triggers like infections, metabolic acidosis, and foods and drinks like fava beans, soy products, red wine, and others. A high-yield fact is that certain medications also act as oxidant stressors, like the antimalarials, primaquine and chloroquine, painkillers like aspirin and ibuprofen, quinidine that's used to treat arrhythmias, and other medications that contain sulfonamide, like the antibiotic trimethoprim sulfamethoxazole. An interesting fact is that G6PD deficiency protects against Plasmodium falciparum that causes malaria, since it makes the parasite-infected RBC more susceptible to oxidants, which will also kill the malaria parasites. Another less common enzyme defect is pyruvate kinase deficiency. This is an autosomal recessive disorder characterized by decreased levels of an enzyme called pyruvate kinase. Pyruvate kinase is an enzyme involved in glycolysis, which is when glucose gets processed in order to generate energy in the form of adenosine triphosphate, or ATP. So, deficiency of this enzyme makes RBCs deficient in ATP. Without ATP, sodium-potassium ATPase pumps stop working, and because the cell membrane is more permeable to potassium than sodium, potassium leaks out. This makes intracellular fluid hypotonic, so water moves out of the cell, and the cell shrinks. These dehydrated RBCs can form tiny uniform projections, turning into echinocytes, or Burr cells. And these abnormally shaped RBCs get trapped and destroyed in the spleen, resulting in extravascular hemolysis. Another high-yield fact is that pyruvate kinase-deficient RBCs show enhanced oxygen delivery. That's because the block in glycolysis results in the buildup of a metabolic intermediate called 2,3-bisphosphoglycerate, or 2,3-BPG for short. 2,3-BPG has a strong affinity for hemoglobin, so within tissues, it competes with oxygen, thus reducing oxygen-hemoglobin affinity, allowing more oxygen to be released from hemoglobin to the tissues. Okay, let's move on to hemolytic anemia due to hemoglobin defects. The most common ones are sickle cell disease, also called sickle cell anemia, and hemoglobin C or HBC disease. These are autosomal recessive disorders caused by mutated genes that encode for abnormal adult hemoglobin, called hemoglobin S for sickle or HBS, and hemoglobin C or HBC. There's substitution of glutamic acid in the 6th position of the beta-globin chain, with valine in the case of HBS and lysine in the case of HBC. A mutation in both copies of the gene is needed to get the disease. If the person has just one copy of the mutation and one normal hemoglobin A gene, or HbA for short, then they have an HbS or HbC trait, and they're said to be a carrier. Some individuals have HbSC disease, meaning that they have one of each mutant gene. An important fact to remember is that, like G6PD deficiency carriers, sickle cell and HbC carriers are also protected against malaria, probably because infected RBCs get removed by the spleen. Now, in individuals with sickle cell disease, when there's acidosis, hypoxia, or dehydration, HbS changes its shape and aggregates with other HbS proteins to form long chains that distort the RBC into a crescent shape that looks like a sickle. In individuals with HbC disease, HbC is less soluble, so it aggregates into crystals, which build up in red blood cells, making them more rigid. And since there is less soluble hemoglobin, there's a relative membrane excess, so red blood cells start resembling a shooting target with a bullseye, with a dark center of hemoglobin, a ring of pallor, and an outer band of hemoglobin. In both cases, this leads to both intravascular and extravascular hemolysis, resulting in increased RBC breakdown, causing jaundice and gallstones, as well as anemia. There's also increased compensatory erythropoiesis in the bone marrow, leading to new bone formation, and extramedullary hematopoiesis, leading to hepatomegaly. In the case of sickling, there's also vaso-occlusion, where RBCs get stuck in capillaries, and that leads to tissue ischemia and pain. Oftentimes, it's an emergency, called sickle cell crisis or vaso-occlusive crisis. Alright, now whatever the cause of hemolytic anemia, all of them can present with symptoms of anemia, like fatigue, pallor, and shortness of breath, and symptoms of hemolysis like jaundice, dark, tea-colored urine, and back pain due to kidney damage. Each of these diseases also has specific symptoms that's special to them, and these will help you to identify them. In hereditary spherocytosis, because hemolysis is extravascular and occurs in the spleen, there's often splenomegaly. For your exams, remember that individuals with hereditary spherocytosis have chronic hemolysis since birth, and thus they can develop bilirubin stones and cholelithiasis at an early age. Another important fact to remember is that anemia is usually mild, but can be severe if there is folate deficiency or aplastic crisis due to parvo B19 infection. In this case, reticulocyte count will be low. Now, in paroxysmal nocturnal hemoglobinuria, these individuals present with dark urine most commonly in the first morning urine, since urine collects and concentrates during the night. They can also present with episodes of venous thrombosis that could lead to pulmonary embolism and hepatic vein thrombosis, also known as Budd-Chiari syndrome. Next are enzyme defects, starting with G6PD deficiency. For the test, remember that most of the patients with G6PD deficiency are completely asymptomatic until exposed to an oxidative stressor and develop symptoms of acute hemolysis and anemia. For pyruvate kinase deficiency, what you need to remember is that it typically presents with jaundice in a newborn, and since hemolysis is extravascular and occurs in the spleen, there's often splenomegaly. Let's move on to hemoglobin defects, and specifically sickle cell disease. During sickle cell crisis, the pain starts suddenly, can last from hours to days, and is excruciating. It can occur within bones of the hands and feet, called dactylitis, in the hip, causing avascular necrosis, in the penis, causing priapism, and in the cerebral vasculature, causing a stroke, mental status changes, and moyamoya disease, named for the puff of smoke that you see on radiographs from the collateral blood vessels that develop over time to bypass blocked arteries. If it happens in the kidneys, it can lead to necrosis and cause hematuria or proteinuria, while in the lungs, it can lead to acute chest syndrome, presenting with chest pain, shortness of breath, or cough. Sickling in bones can lead to bone necrosis, predisposing to osteomyelitis. For the exams, remember that the most common cause of osteomyelitis in children with sickle cell disease is Salmonella, while Staphylococcus aureus and Escherichia coli are also common. Okay, now bone marrow compensation causes the medullary cavities of the skull to expand, which causes enlarged cheeks and a hair-on-end appearance on X-ray, while extramedullary hematopoiesis presents with hepatomegaly. Additionally, a large portion of circulating blood volume can get trapped in the spleen, causing it to massively enlarge, which is known as splenic sequestration, and it's a life-threatening complication. There's usually a rapid drop in hemoglobin, leading to hypovolemic shock over a few hours. Another high-yield fact to remember is that RBCs can clog up the spleen, which can lead to splenic infarcts and autosplenectomy. Biopsy of the spleen will reveal significant fibrosis and atrophy, and since the spleen plays an important role in immunity against encapsulated bacteria, the person will be susceptible to Streptococcus pneumoniae, Haemophilus influenza, and Neisseria meningitidis infections. Now, chronic complications of sickle cell disease include growth and developmental delay, learning and behavior issues, pulmonary hypertension, and chronic kidney disease. Alright, now sickle cell carriers are basically asymptomatic unless they're exposed to high altitude or dehydration. However, in sickle cell carriers, sickling can occur in the renal medulla since the renal cortex gets all the blood and the medulla is more hypoxic and acidotic, causing papillary necrosis and isostenuria or inability to concentrate their urine. Then, for HBC disease, symptoms are nonspecific and might even be absent, except for mild symptoms of hemolytic anemia, especially under stress. And with HBSC disease, symptoms are similar to sickle cell disease, but less frequent and less severe. Moving on to diagnosis. In hereditary spherocytosis, the peripheral blood smear shows spherocytes that are slightly smaller than normal, round, dysmorphic RBCs with more intensely stained cytoplasm and no central pallor. The mean corpuscular volume, MCV, can be normal or slightly decreased. The mean corpuscular hemoglobin, or MCH, is normal, meaning that every RBC has the correct amount of hemoglobin, but the mean corpuscular hemoglobin concentration, or MCHC, is increased due to membrane loss and RBC dehydration. So, for the test, remember that increased MCHC can be helpful in making the diagnosis. Spherocytes also have increased sensitivity to lysis in hypotonic solutions, known as the osmotic fragility test. But it's not specific for hereditary spherocytosis and is also present in autoimmune hemolytic anemia. However, the Coombs test is positive in autoimmune hemolysis and negative in hereditary spherocytosis, which can help distinguish these two disorders. The treatment is splenectomy to prevent hemolysis in the spleen. In paroxysmal nocturnal hemoglobinuria, PNH, there are findings of intravascular hemolysis such as low haptoglobin, hemoglobinuria, and hemosideриnuria. The gold standard test is flow cytometry, which shows deficiency of CD55 and CD59. Treatment includes eculizumab, which is an antibody against the complement protein C5. Now, to diagnose G6PD deficiency, the peripheral blood smear can be very helpful. Free radicals damage hemoglobin molecules, which then precipitate inside the cells, and are seen as dark inclusions, called Heinz bodies, when stained with crystal violet stain. The splenic macrophages notice these Heinz bodies and try to remove them by taking a bite out of the cells, leaving these RBCs partially devoured, so we call them bite cells. The diagnosis is suspected if there's a history of recent exposure to an oxidant, like starting a new medication or eating fava beans, followed by a hemolytic episode. But the definitive test for G6PD deficiency diagnosis is an enzyme assay to detect the levels of G6PD. Now, the assay shouldn't be done during the hemolytic episode, since the cells with low enzyme levels are dead, and the levels of G6PD will be falsely normal. Given the high risk of hemolysis, it's important to diagnose G6PD deficiency as early as possible, so newborns in many developed countries are tested a few days after birth. Likewise, diagnosis of pyruvate kinase deficiency starts with a peripheral blood smear, which may show the characteristic echinocytes or Burr cells. But definitive diagnosis comes with an enzyme assay, showing low levels of pyruvate kinase. Once again, the assay shouldn't be done during the hemolytic episode, since the levels of pyruvate kinase will be falsely normal. In severe cases, the treatment is a splenectomy to prevent hemolysis in the spleen. Hemoglobin defects can be diagnosed with prenatal testing for hemoglobin gene mutations. A sample of the fetal DNA can be obtained through either chorionic villus sampling or amniocentesis. In some settings, hemoglobin defects are tested for in newborn screening by using hemoglobin electrophoresis. In a newborn with sickle cell disease, it'll show an intense band of hemoglobin F, or HbF, and another lighter band of HbS instead of the adult hemoglobin A, or HbA. A newborn with sickle cell trait will have an HbF as well as two separate HbS and HbA bands. A newborn with HBC disease will have an intense band of HbF and another lighter HbC band, while a newborn with HBC trait will have an HbF and two separate HbC and HbA bands. And a newborn with HBSC disease will have an HbF as well as an HbS and HbC band. If newborn screening is not done, then the diagnosis is made later on. A peripheral blood smear can show target cells with hemoglobin C crystals in HBC disease, or cells that are sickled in sickle cell disease. Individuals with sickle cell disease may have a spleen that's non-functional or absent. The smear will also show Howell-Jolly bodies, which are basophilic nuclear remnants in RBCs. These are normally not seen because a healthy spleen would instantly filter and remove these RBCs. Finally, the diagnosis will be confirmed with hemoglobin electrophoresis, which is the most specific test. In this case, a healthy individual will have an intense band of HbA. An individual with sickle cell disease will have an intense band of HbS. And an individual with sickle cell trait will have two almost equal bands of HbS and HbA. Similarly, someone with HBC disease would have an intense band of HBC. Someone with HBC trait would have two almost equal bands of HBC and HbA, while someone with HBSC disease would have two almost equal bands of HbS and HbC. Additionally, there's a screening test for sickle cell trait known as the sickle prep or sickle dex, but it cannot distinguish trait from homozygous disease. Treatment of sickle cell disease includes hydroxyurea, which reactivates the synthesis of fetal hemoglobin to replace the abnormal hemoglobin S, so there's a lower chance of sickling. Hydration may also help, both during sickle cell crises as well as for prevention. In contrast, HBC disease typically needs no treatment. Okay, to review. Intrinsic hemolytic anemias occur when RBCs are abnormal. There are RBC membrane defects, like in hereditary spherocytosis and PNH, enzyme deficiencies, like in G6PD deficiency and pyruvate kinase deficiency, and hemoglobin abnormalities, like in sickle cell anemia. Hemolysis can be extravascular, like in hereditary spherocytosis and pyruvate kinase deficiency, intravascular, like in PNH, or both, like in G6PD deficiency and sickle cell anemia. A diagnosis can be made based on clinical presentation and lab findings. The diagnosis can often be confirmed with more specific tests, like the osmotic fragility test, enzyme assay, and hemoglobin electrophoresis. Now, back to the patients. All of them have normocytic hemolytic anemia. Kira most likely has hereditary spherocytosis. Her young age, unknown family history, splenomegaly, increased MCHC, and the presence of spherocytes on peripheral blood smear are important clues for the diagnosis, which can be confirmed with the osmotic fragility test. A Coombs test should also be done to rule out autoimmune hemolytic anemia. Now, Darnell most likely has G6PD deficiency due to his history of a hemolytic episode after taking a medication that contains sulfonamide. Also, G6PD deficiency presents almost exclusively in males and is common in individuals of African descent, like Darnell. To confirm the diagnosis, an enzyme assay for G6PD must be ordered. Meanwhile, Billy has priapism, and due to the presence of sickled cells on peripheral blood smear, he most probably has sickle cell anemia. A hemoglobin electrophoresis should be ordered to confirm the diagnosis.
In the hematology ward, 2 people came in with the same symptoms: easy fatigability, exertional dyspnea, and weight loss. One of them is a 65-year-old Caucasian individual named Bobby, and the other one is a 50-year-old Hispanic individual named Sarah. Bobby complains of frequent falls, while Sarah admits she is a chronic user of alcohol. Their lab tests show decreased hemoglobin levels. Both Bobby and Sarah are suffering from anemia, which is defined as lower than average levels of hemoglobin, typically below 13.5 grams per deciliter in adult men and below 12.0 grams per deciliter in adult women. Now, anemias can be broadly grouped into 3 categories based on mean corpuscular volume, or MCV, which reflects the volume of a red blood cell, or RBC. So microcytic anemia is where the MCV is lower than 80 femtoliters. Normocytic with an MCV between 80 and 100 femtoliters, and macrocytic with an MCV larger than 100 femtoliters. Now let's focus on the macrocytic anemias. The 2 most common causes are vitamin B12 deficiency and folate deficiency. Orotic aciduria, Fanconi anemia, Diamond-Blackfan anemia are also macrocytic. Finally, liver diseases and hypothyroidism can also cause this type of anemia, but their mechanisms are not well understood. Okay, macrocytic anemias can be classified based on the presence of megaloblasts. These are large, immature red blood cells produced when the cytoplasm develops normally, but the DNA synthesis is impaired and cell division is delayed. So when there's defective DNA synthesis or defective DNA repair, like in folate deficiency, vitamin B12 deficiency, orotic aciduria, and Fanconi anemia, there's megaloblastic, macrocytic anemia. Megaloblastic anemia can also affect white blood cell production, so the bone marrow starts releasing large, immature neutrophils with hypersegmented nuclei, meaning their nucleus has more than 5 lobes. These are called hypersegmented neutrophils and are a key finding on the peripheral blood smear of individuals suffering from megaloblastic anemia. So for your exams, remember that the peripheral blood smear in megaloblastic anemias shows RBC macrocytosis, megaloblasts, and hypersegmented neutrophils. Alright, now in Diamond-Blackfan anemia and liver disease, DNA synthesis is not impaired, and there's non-megaloblastic macrocytic anemia. The peripheral blood smear shows RBC macrocytosis without megaloblasts or hypersegmented neutrophils. Okay, so let's take a closer look at these different anemias, starting with vitamin B12 or cobalamin deficiency. One cause is decreased dietary intake because vitamin B12 is found in animal and dairy products such as eggs, meat, or milk. So it's often seen in vegans who don't take vitamin supplements. An important fact is that large quantities of B12 are stored in the liver, so it could take years for decreased dietary intake symptoms to develop. For your exams, it's important to know that the most common cause of vitamin B12 deficiency is defective absorption, and you need to know the different ways this could happen. One cause is gastric atrophy. Now normally, dairy and animal products are broken down in the stomach by pepsin, which releases B12. For this to happen, the stomach must be very acidic in order to convert pepsinogen into pepsin. Now in gastric atrophy, there's a decrease of hydrochloric acid production in the stomach, which leads to decreased acidity and prevents the release of vitamin B12. Gastric bypass is another potential cause, since food passes through the stomach too quickly and not enough B12 is released. Another cause of decreased absorption is pernicious anemia. Okay, so the stomach parietal cells make a protein called intrinsic factor, which binds to vitamin B12. And this complex passes into the intestines. When the complex reaches the terminal ileum, the enterocytes recognize the intrinsic factor and absorb the whole complex. In pernicious anemia, the body produces antibodies against intrinsic factor or parietal cells, leading to decreased absorption. Also, any terminal ileal diseases, like inflammatory bowel disease or ileal resection, can damage the enterocytes and prevent absorption. Finally, infections like Diphyllobothrium latum, or fish tapeworm, and bacterial overgrowth in the ileum also interfere with absorption, leading to vitamin B12 deficiency. Now, vitamin B12 is used to synthesize DNA precursors, which is essential for cell division. When B12 levels are low or absent, cell division is impaired. So rapidly dividing cells, like those in the bone marrow, are the most affected. This includes precursors for platelets and both red and white blood cells, leading to thrombocytopenia, anemia, and possibly to leukopenia. When all three blood cell lines are affected, it's called pancytopenia. Another high-yield fact is that B12 deficiency increases homocysteine and methylmalonic acid in the body. This is because vitamin B12 is an important cofactor that aids the conversion of homocysteine to methionine and the conversion of methylmalonyl-CoA to succinyl-CoA. Okay, moving on to folate or vitamin B9 deficiency, which can be caused by decreased dietary intake, increased demand, or impaired absorption. Main sources of vitamin B9 include leafy greens and citrus fruits like oranges and lemons. Now, folic acid present in these foods are generally in the polyglutamate form, which is almost non-absorbable. So special enzymes in the jejunal mucosa, like the intestinal conjugase, cut down the polyglutamate residues into monoglutamate, which can be absorbed. Once inside the enterocytes of the jejunum, an enzyme called dihydrofolate reductase convert it into tetrahydrofolic acid, or THF, which then goes into the portal circulation. Now, the liver also stores some vitamin B9 along with vitamin B12, but only enough vitamin B9 for a few months, while there's enough B12 stored for years. So for your exams, remember that an individual with a folate-deficient diet will experience symptoms more rapidly than B12 deficiency. Folate deficiency due to increased demand occurs in conditions like pregnancy and hemolytic anemias because more red blood cells need to be produced. For impaired absorption, medications like phenytoin, trimethoprim, methotrexate, sulfasalazine, as well as alcohol, can interfere with folic acid absorption in the jejunum. More specifically, phenytoin inhibits the intestinal conjugase, which normally converts the polyglutamate form of folate into monoglutamate. Trimethoprim inhibits dihydrofolate reductase, which converts dihydrofolate into tetrahydrofolate. And alcohol, like sulfasalazine, decreases the expression of a transporter protein that moves folic acid from the enterocytes to the portal vein. Now, folic acid is used to synthesize purines and pyrimidines, which are essential for DNA replication and cell division. So in the absence of folic acid, cell division is impaired, and therefore rapidly dividing cells in the bone marrow are affected, like red and white blood cells, as well as platelet precursors, leading to anemia, leukopenia, and thrombocytopenia. For the test, remember, homocysteine levels are elevated, like vitamin B12 deficiency, but methylmalonic acid levels are normal. This is because folate is a cofactor that aids the conversion of homocysteine to methionine, but does not affect the conversion of methylmalonyl-CoA to succinyl-CoA. Next up is orotic aciduria, where there's excessive excretion of orotic acid in urine. The main concept you'll need to know is that orotic aciduria is an autosomal recessive disorder characterized by a deficiency of the enzyme uridine monophosphate synthase, or UMP synthase, which normally converts orotic acid to UMP. UMP is an important precursor of pyrimidines, and thus, orotic aciduria leads to defective DNA synthesis and megaloblastic anemia. Now, there's Fanconi anemia, which is a genetic form of aplastic anemia caused by mutations in DNA repair enzymes. So in Fanconi anemia, many precursor blood cells in the bone marrow are affected and accumulate DNA damage, causing them to undergo cell death. If enough cells are affected, it can lead to bone marrow failure and pancytopenia. Affected individuals are also at risk of developing cancers like acute leukemia, as well as tumors of the head, neck, skin, gastrointestinal system, or genital tract. Okay, moving on to non-megaloblastic anemia, which includes Diamond-Blackfan anemia and liver disease. Diamond-Blackfan anemia is a genetic disorder caused by mutations in the genes for ribosomal proteins. The ribosomal proteins are mainly involved in protein synthesis, but also regulate cell division and cell death. Impaired function of ribosomal proteins affects the erythroid progenitor cells, resulting in anemia. But remember for your test that white blood cells and platelets are usually not affected. Now, all anemias can cause fatigue, pallor, shortness of breath, and glossitis, but other symptoms can help you identify the specific disease. For vitamin B12 deficiency anemia, there is neurological dysfunction, because when there's too much methylmalonic acid in the body, it builds up in the neurons, specifically in their myelin sheath, which degenerates. The main sites of neurological involvement include the peripheral nerves and the spinal cord, causing subacute combined degeneration, or SCD, which due to affected dorsal columns cause decreased vibratory and position sense, and affected lateral corticospinal tracts cause spastic paresis. It affects the cerebrum, causing dementia or psychiatric symptoms as early signs of B12 deficiency. It also affects the cerebellum, and as a result, patients experience ataxia and recurrent falls. In folate deficiency, methylmalonic acid levels are normal, so no neurologic symptoms occur. And that is something you absolutely have to remember. For orotic aciduria, it usually manifests in childhood and presents as failure to thrive and developmental delay. For Fanconi anemia, there are physical abnormalities like short stature, thumb and arm defects, and skin markings called café au lait spots, which are flat patches that are the color of milky coffee. Now, Diamond-Blackfan anemia usually manifests during infancy, and the individuals affected also have physical abnormalities like short stature, craniofacial abnormalities such as small head size or microcephaly, cleft palate, cleft lip, and small lower jaw called micronathia, as well as upper extremity malformations, most commonly malformed or absent thumbs. Let's switch gears and look at some important lab tests. The diagnosis of vitamin B12 deficiency relies on a peripheral blood smear, which shows large red blood cells and hypersegmented neutrophils. A bone marrow study can also be done to look for the megaloblastic changes in RBC precursors at various stages of differentiation. Homocysteine and methylmalonic acid levels are elevated. Next, diagnosis of folate deficiency also relies on a peripheral blood smear and bone marrow study, both of which shows the same finding as B12 deficiency. However, keep in mind that the homocysteine level is elevated, but methylmalonic acid levels are normal. Orotic aciduria is diagnosed via the very high orotic acid excretion in urine. Genetic testing can be done to confirm the diagnosis. The definitive test for Fanconi anemia is a chromosome breakage test where the ability of the patient's blood cells to repair DNA damage is tested. Diamond-Blackfan anemia diagnosis is mainly made through bone marrow biopsy, which shows diminished erythroid precursors. The important fact to remember for exams in Diamond-Blackfan anemia is that fetal hemoglobin, or HbF, is elevated to compensate for the decreased production of red blood cells. Okay, to review. Macrocytic anemias can occur when there is defective DNA synthesis, like in vitamin B12 deficiency, folate deficiency, and orotic aciduria, defective DNA repair, like in Fanconi anemia, and in other conditions such as Diamond-Blackfan anemia and liver disease. Vitamin B12 deficiency and folate deficiency, however, are by far the two most common causes of macrocytic anemia. A diagnosis can be made based on peripheral blood smear and bone marrow study, but also consider the other symptoms, clinical history, lab findings, and genetic tests. Now back to the patients. Due to his age and frequent falls, indicating neurological dysfunction, Bobby most likely has vitamin B12 deficiency, which can be confirmed with a peripheral blood smear. First, low dietary intake should be ruled out. Then, to pinpoint the cause of decreased absorption, one can look for anti-intrinsic factor antibodies for pernicious anemia, or carry out endoscopic or imaging studies in younger patients that might have Crohn's disease. Meanwhile, Sarah probably has folate deficiency anemia, based on her history of chronic alcohol use. Confirmation of the diagnosis can be done with peripheral blood smear findings, along with homocysteine and methylmalonic acid levels.
Plasma cell disorders are a group of hematological malignancies that primarily happen in the elderly, and are characterized by unregulated proliferation of plasma cells in the bone marrow. They include multiple myeloma, monoclonal gammopathy of unknown significance, or MGUS, and Waldenstrom's macroglobulinemia. Each of them produce a monoclonal or M protein, which is a unique protein of a single type, like a protein clone. In multiple myeloma, the most common M protein that's produced is IgG, followed by IgA, and these M proteins have both a heavy and a light chain. More rarely, the myeloma cells only make the kappa or lambda light chain of the immunoglobulin, and in that situation, the resulting protein is called the Bence-Jones protein. The clinical presentation of multiple myeloma can be summarized by the mnemonic CRAB, where C is for hypercalcemia, resulting from increased osteoclast activity due to the release of osteoclast activating factor from the plasma cells, R is for renal disease, which is generally due to the light chains depositing and obstructing the renal tubules. And this is called light chain cast nephropathy, or myeloma kidney. Renal disease can also be due to type 2 renal tubular acidosis, as well as secondary amyloidosis, or even hypercalcemia. A is for anemia, which causes fatigue and shortness of breath, and is often due to infiltration of the bone marrow by the plasma cells. And finally, B is for bone pain, which is due to increased osteoclast activity, causing lytic bone lesions. Other manifestations include spinal cord compression if the tumor infiltrates from the vertebrae, and infections because the immunoglobulins produced by the malignant plasma cells are not useful in fighting infections. A workup for multiple myeloma includes a CBC, which often shows normocytic normochromic anemia, and a peripheral smear, which can show a Rouleau's formation due to IgG proteins attaching to red blood cell membranes, and then connecting with other red blood cell membranes, making the red blood cells stick to each other and causing them to look like a stack of coins. Additionally, serum calcium levels, blood urea nitrogen, and creatinine concentrations might be elevated. Also, uric acid levels might be elevated due to increased cell turnover. Serum and urine protein electrophoresis, or SPEP and UPEP, respectively, are important to see which M protein is predominantly being produced, and is seen as an M spike. SPEP detects most multiple myeloma patients that predominantly make IgG, followed by IgA, while UPEP is used to detect the minority of multiple myeloma patients who only make the Bence-Jones protein. UPEP is needed because these light chains are rapidly filtered from the blood, so they might not be seen on SPEP. A urine dipstick is not sufficient, as it only detects albumin. Also, beta-2 microglobulin, a component of the major histocompatibility class 1 antigens found on all nucleated cells, can be shed in the serum. Serum levels of beta-2 microglobulin are checked in multiple myeloma, because the higher they are, the higher the severity of the disease. Then a skeletal radiographic survey should be done to look for punched-out lytic lesions. A bone scan should not be obtained, as it only detects osteoblastic lesions, not osteolytic lesions. Finally, a bone marrow aspiration and biopsy must be obtained to look for more than 10% plasma cells which infiltrate into the bone marrow. Now, 3 criteria must be met to diagnose multiple myeloma. First, at least one of the Crab symptoms. Second, M protein in either the urine or serum. And third, more than 10% plasma cells in the bone marrow. Treatment includes chemotherapeutic regimens, like combining lenalidomide or melphalan with dexamethasone or bortezomib. Patients less than 70 years old may undergo hematopoietic stem cell transplantation. These patients are immunosuppressed, so they need vaccination against Streptococcus pneumoniae, Haemophilus influenzae, and influenza A. In case of spinal cord compression, irradiation is used to target the involved area. Finally, complications should be treated, like giving bisphosphonates for lytic lesions and hypercalcemia, and providing dialysis in cases of renal failure. Moving on, MGUS is a pre-malignant plasma cell disorder that makes an M protein which is usually IgG, so calling it monoclonal gammopathy makes sense. In some cases, it leads to multiple myeloma or another malignancy, but it doesn't always, so that's why there's a term undetermined significance. Classically, patients are SPEP positive for IgG, so you might instinctively think, oh, it's multiple myeloma. But the difference is that MGUS is completely asymptomatic. The skeletal survey is negative, and a bone marrow biopsy will show less than 10% plasma cells. No treatment is required, but patients should be routinely monitored for disease progression by repeating lab workup every 6 months. There's about a 1% per year risk of progression to multiple myeloma. Typically, a rebiopsy is only done if the labs indicate progression. Waldenstrom's macroglobulinemia is unique because it's actually a rare type of B-cell lymphoma called lymphoplasmocytic lymphoma. But since the cells secrete the M protein, IgM, it's classified as a plasma cell disorder. To help you remember this, macroglobulinemia literally means large protein, and IgM is the largest of the immunoglobulins. Generally, these patients don't have Crab symptoms, but instead have fatigue, frequent infections, and easy bleeding from pancytopenia, as well as hepatosplenomegaly and lymphadenopathy. Also, patients might develop hyperviscosity syndrome, in which IgM, being pentameric in structure and plentiful in amount, occludes small blood vessels, causing ischemia of the affected tissues. Symptoms include visual impairment, peripheral neuropathy, headache, altered mental status, and dizziness. Hyperviscosity syndrome is treated with plasmapheresis, which rapidly filters out the excess IgM from the plasma. IgMs can also inappropriately act as an autoantibody against red blood cells, causing autoimmune hemolytic anemia. The autoantibody can also attack the sheath of nerves, causing peripheral neuropathy. In Waldenstrom's macroglobulinemia, the SPEP will be positive for IgM, and similar to MGUS, the skeletal survey will often be negative. But unlike MGUS, bone marrow biopsy will show more than 10% lymphoplasmacytic cells. Treatment includes chemotherapy with alkylating agents like cyclophosphamide, and monoclonal antibodies like rituximab. Alright, as a quick recap. Plasma cell disorders are a group of bone marrow neoplasms that make a characteristic M protein, and include multiple myeloma, which usually makes IgG, monoclonal gammopathy of undetermined significance, or MGUS, which also usually makes IgG, and Waldenstrom's macroglobulinemia, which usually makes IgM. Multiple myeloma patients present with CRAB symptoms, which are hypercalcemia, renal disease, anemia, and bone pain. A skeletal survey shows lytic bone lesions, and a bone marrow biopsy reveals more than 10% plasma cells. MGUS, on the other hand, is usually asymptomatic, has no bone lesions, and a bone marrow biopsy shows less than 10% plasma cells. Waldenstrom's macroglobulinemia patients can have hyperviscosity syndrome or autoimmune hemolytic anemia. And a bone marrow biopsy often shows more than 10% lymphoplasmacytic cells.
At the family medicine department, a 70-year-old male named Ian came in with progressive fatigue and chronic back pain. His lab tests show anemia with an MCV of 90, as well as increased calcium, blood urea nitrogen, and creatine levels. Peripheral blood smear showed the following. Next to Ian, there's a 65-year-old female named Amanda who complains of progressive fatigue, recurrent nosebleeds, and blurred vision. Clinical examination reveals palpable liver and spleen. Her lab tests show anemia with normal MCV, reticulocyte count index over 2%, increased LDH, and a positive Coombs test. Although their symptoms are very different, both Ian and Amanda have a plasma cell disorder. Plasma cell disorders are a group of hematological malignancies that are characterized by unregulated proliferation of plasma cells in the bone marrow. They include multiple myeloma, monoclonal gammopathy of unknown significance, or MGUS, and Waldenstrom's macroglobulinemia. Each of them produce monoclonal or M protein, which is a unique protein of a single type, like a protein clone. Because plasma cells normally make immunoglobulins, it's not surprising that the M proteins produced are also immunoglobulins. Alright, now let's take a closer look at these different plasma cell disorders, starting with multiple myeloma, which is the most common primary bone tumor in people between 40 and 50 years of age. In multiple myeloma, the most common M protein produced is IgG, followed by IgA, and these immunoglobulins have both a heavy and a light chain. More rarely, the myeloma cells can only make the kappa and lambda light chain of the immunoglobulin, and in that situation, the resulting protein is called a Bence-Jones protein. A high-yield concept is the clinical presentation of multiple myeloma, which can be summarized with the mnemonic CRAB. C is for hypercalcemia, which results from increased osteoclast activity due to the release of osteoclast activating factor from the malignant plasma cells, which resorbs the bone and releases free calcium into the circulation. Remember that your exam might not give you the lab finding, but instead give you some symptoms of hypercalcemia, such as abdominal pain, psychiatric changes, constipation, or fatigue. Okay, R is for renal disease, which can be caused by multiple mechanisms. First, the light chains can deposit in and obstruct the renal tubules, and this is called light chain cast nephropathy, or myeloma kidney. Renal disease can also be due to type 2 renal tubular acidosis, or even hypercalcemia, which may cause the formation of calcium phosphate kidney stones. Multiple myeloma can also lead to a specific type of amyloidosis, called primary amyloidosis. Here, the immunoglobulin light chains leave the circulation and abnormally aggregate in various tissues, resulting in various clinical manifestations. These include restrictive cardiomyopathy, a large tongue, also called macroglossia, and nephrotic syndrome, to name a few. So on the exam, beware of primary amyloidosis being a presenting feature of multiple myeloma. A is for anemia, which causes fatigue and shortness of breath. The anemia occurs because the malignant cells infiltrate the bone marrow and disrupt the normal production of red blood cells. Finally, B is for bone pain, which is due to increased osteoclast activity, causing pathologic fractures and lytic bone lesions. So, in the exams, look for an elderly individual with symptoms of anemia and chronic back pain. Other manifestations include spinal cord compression if the tumor infiltrates from the vertebrae, and frequent infections, because although the tumor is making lots of immunoglobulins, they are not functional immunoglobulins, and so they are not useful in fighting infections. So for the test, remember that a workup for multiple myeloma includes a CBC, which often shows normocytic normochromic anemia, and a peripheral smear, which can show a Rouleau's formation, due to IgG proteins attaching to red blood cell membranes and then connecting with other red blood cell membranes, making the red blood cells stick to one another, causing them to look like a stack of coins. Serum and urine protein electrophoresis, or SPEP and UPEP, respectively, are important to see which M protein is predominantly being produced and is seen as an M spike. SPEP detects most multiple myeloma patients that predominantly make IgG, followed by IgA, while UPEP is used to detect the minority of multiple myeloma patients who only make the Bence-Jones protein. UPEP is needed because these light chains are rapidly filtered from the blood, so they may not be seen on SPEP. A urine dipstick is not sufficient, as it only detects albumin. Also, beta-2 microglobulin, a component of the major histocompatibility class 1 antigens found on all nucleated cells, can be shed in the serum. Serum levels of beta-2 microglobulin are checked in multiple myeloma because the higher they are, the more severe the disease. Then, a skeletal radiographic survey should be done to look for punched-out lytic lesions. A bone scan should not be obtained, as it only detects osteoblastic lesions, not osteolytic lesions. Finally, another high-yield fact is that a bone marrow aspiration and biopsy must be obtained to look for more than 10% plasma cells which infiltrate into the bone marrow. Remember that plasma cells tend to have a fried egg appearance, where the large nucleus located at the edge of the cell is the yolk, and the cytoplasm is the egg white. In the cytoplasm, you might see immunoglobulin inclusion bodies. Now if we zoom in on the nucleus, we can see another distinguishing feature called clock-phase nuclei, where the chromatin forms a ring like the numbers on a clock. Moving on, monoclonal gammopathy of undetermined significance, or MGUS, is a pre-malignant plasma cell disorder that makes an M protein which is usually IgG, so calling it monoclonal gammopathy makes sense. There's about a 1% per year risk of progression to multiple myeloma or other malignancy, so that's why there's the term undetermined significance. Okay, now, unlike multiple myeloma, MGUS doesn't present with Crab findings, and it's completely asymptomatic. Also, patients have an SPEP positive for IgG, so you might instinctively think it's multiple myeloma. But the difference is that MGUS is completely asymptomatic, the skeletal survey is negative, and a bone marrow biopsy will show less than 10% plasma cells. Finally, Waldenstrom's macroglobulinemia is unique because it's actually a rare type of B-cell lymphoma called lymphoplasmacytic lymphoma. But since the cells secrete the M protein, IgM, it's classified as a plasma cell disorder. To help you remember this, macroglobulinemia literally means large protein, and the IgM is the largest of the immunoglobulins. Although it's commonly asymptomatic, the symptoms that do occur are mainly attributed to hyperviscosity syndrome, which leads to mucosal bleeding from the nose and gums. In the eyes, distension of retinal veins causes retinopathy or blurring and loss of vision. Raynaud phenomenon is another common symptom where the tips of the fingers turn blue or white when exposed to cold. IgMs can also inappropriately act as autoantibodies against red blood cells, causing autoimmune hemolytic anemia, which typically presents with fatigue and general weakness. Autoantibodies can also attack the sheaths of nerves, causing peripheral neuropathy. Lastly, the immunoglobulins tend to accumulate in the lymph nodes, spleen, and liver, making these organs enlarge, and causing lymphadenopathy, splenomegaly, and hepatomegaly, respectively. Finally, the SPAP will be positive for IgM, and similar to MGUS, the skeletal survey will often be negative. But, unlike MGUS, bone marrow biopsy will show more than 10% lymphoplasmacytic cells. Okay, to review. Plasma cell disorders are a group of bone marrow neoplasms that make characteristic monoclonal proteins. They include multiple myeloma, which usually makes IgG, monoclonal gammopathy of undetermined significance, or MGUS, which also makes IgG, and Waldenstrom's macroglobulinemia, which usually makes IgM. Multiple myeloma patients present with CRAB symptoms, which are hypercalcemia, renal disease, anemia, and bone pain. A skeletal survey shows lytic bone lesions, and a bone marrow biopsy reveals more than 10% plasma cells. MGUS, on the other hand, is usually asymptomatic, with no bone lesions, and a bone marrow biopsy shows less than 10% plasma cells. Waldenstrom's macroglobulinemia patients have hyperviscosity syndrome or autoimmune hemolytic anemia. A bone marrow biopsy often shows more than 10% lymphoplasmacytic cells. Now, back to the patients. Due to his age and the presence of normocytic anemia, bone pain, hypercalcemia, and renal insufficiency, which are all CRAB findings, Ian most likely has multiple myeloma. Rouleau's formation on peripheral blood smear is also a clue for multiple myeloma. SPEP and UPEP will be sent to see which M protein is predominantly being produced, and a skeletal radiographic survey should be done to look for punched-out lytic lesions. To confirm the diagnosis, a bone marrow aspiration and biopsy must be obtained, to look for more than 10% plasma cells, which infiltrate into the bone marrow. Now Amanda has symptoms of hyperviscosity, such as nosebleeds and blurred vision, hepatosplenomegaly, and autoimmune hemolytic anemia, so she most likely has Waldenstrom's macroglobulinemia. To confirm the diagnosis, SPEP must be positive for IgM and bone marrow biopsy, which will show more than 10% plasma cells.